All right, last recording for chapter 35. It's oftentimes that when we're going to deal with a patient within the geriatric population, we may be going to a nursing home or some other skilled care facility, which can be challenging, is a nice way to put it. Oftentimes, our patients will have altered level of consciousness, may not be able to give us a whole lot of information, but really the most important thing for us to ask right off is what's wrong with the patient that is new, that's different today, that actually um, made you feel the need to call 911, because the patient's going to have several different issues and they often try to give us a lot of information up front, and it's very hard to kind of sort through that. So just what made you call 911 today? Try and talk with staff who directly care for that patient on a daily basis. Those people may not be available. They may be at a place that they switch their assignments quite frequently. But if you can, just say, is there anybody that takes care of this patient more often than not? Infection control is a huge priority for EMTs when going to a skilled facility. An infection in an older patient can lead to a life-threatening infection, which can lead to sepsis. And there's often a couple of different types of diseases that we're going to run into. So a big one is MRSA, so methicillin-resistant Staphylococcus aureus. They're very common amongst people who are living in close quarters, such as nursing homes. This type of organism can be found in like decubitus ulcers, feeding tubes, indwelling catheters. So we want to make sure that we protect ourselves as well as try and reduce the spread of MRSA. So wash your hands before and after every patient contact, properly dispose of or disinfect medical equipment, and then just make sure that you're taking appropriate standard precautions. Many infections in the hospital are caused by VRE or vancomycin resistant enterococci. RSV or respiratory syncytial virus is an infection of the upper and lower respiratory tracts. It's highly, highly contagious. It's found in discharges from the nose and throat of an infected person. This is not necessarily just a problem in the geriatric population, but pediatrics as well. C. diff or Clostridium difficile is a bacteria that's responsible for hospital-acquired diarrhea, infectious diarrhea. You may come across this when you have a patient that's experiencing diarrhea and you come in contact with any stool type product. The thing with C. diff is that regular alcohol-based sanitizers are not going to kill it. They actually have, for just giving you an idea, they have little hooks on them, and so they actually stick to you, and they're very well protected by an outer shell. So just simply putting on some gel sand or whatever is not going to take care of them. Truthfully, the best thing that you can do is mechanical washing. So actually getting your hands underwater with some soap, scrub to actually remove that from your hands. And C. diff smells terrible. Once you understand that smell, you will pick up on it. Dying patients. Older patients are definitely living a lot longer, but more of the terminally ill or hospice type patients are choosing to die at home rather than a hospital. So they end up receiving what's called palliative care or comfort care or hospice. Palliative care and hospice are not the same thing. Palliative care is even for patients that have a really good prognosis but are dealing with severe pain. It's truthfully about improving quality of life, and it really doesn't matter what the suspected quantity of life is. This either way is going to be focusing on relieving pain, providing emotional support, and then being there for not only the family, but their loved ones. Our interaction with that dying patient is going to have a long lasting effect for the family. So it's really important for us to be understanding, sensitive, and compassionate, even if the patient is unconscious, just really in a grave position. It still warrants them being treated like a person. Advanced directives um, are legal papers that tell the relatives, care providers, etc., what kind of medical treatment the patient wants to receive in case they are incapacitated and can't speak for themselves. A DNR, a do not resuscitate order, is a type of advanced directive. So if something were to happen to the patient where they would stop breathing or their heart would stop, they do not want heroic measures. So no CPR, no shocking. For a DNR order to be valid, the form has to be signed by the patient or legal surrogate and by one or more physicians or other licensed healthcare providers. Just because somebody tattoos DNR on their chest or they have a piece of paper or had a conversation with a family member, that does not constitute a legally binding DNR. DNR does not mean do not treat. If the patient is still alive, we provide supportive measures, including oxygen delivery, pain relief, anything that could make the patient more comfortable. And if there is any question regarding the orders, or if there are no written orders, initiate resuscitation. ABCs should still be provided for. It's often just the heroic measures that they don't want. Another big topic, elder abuse and neglect. This is defined as any action on the part of an older person's family member, caregiver, or other associated person that takes advantage of their person, property, or emotional state. Abuse has a couple of different acts. So there's an act of commission, so words or actions that cause harm, such as verbal, physical, or sexual assault. Or it can be acts of omission, so failure to act, such as denying an older person adequate nutrition or medical care. Oftentimes, we don't think about elder abuse the way that we do think about child abuse. Victims of elder abuse are often hesitant to report the problem to law enforcement agencies or human social welfare agencies. The abused person may feel overly traumatized by the situation, be afraid that the abuser will punish him or her for reporting the abuse, or the abused person is frail, has multiple chronic conditions or dementia, or fear that their caregiver will no longer want to care for them and they'll have to go into a facility. It occurs most often in women that are older than 75 years of age. It's also possible that abusers may be products of child abuse themselves. And so this is kind of their way of getting back at not even necessarily their parent, it may be somebody else. Abuse can occur in several different environments. It may be nursing home, convalescent homes, continuing care centers, and you can end up with physical, psychological, financial, or pharmacologic harm. Oftentimes, geriatric patients are easy targets for people that are trying to score different types of controlled medications. You should suspect abuse when answers to questions about what caused the injury are concealed or avoided. Suspect abuse when you're giving completely unbelievable answers. Different information that may be important when determining if possible abuse has occurred. If the caregiver is relatively apathetic about the patient's condition, overly defensive when you try and ask questions. The caregiver doesn't allow the patient to answer questions for themselves, if there's repeated visits to the emergency department or clinic, or a history of being overly accident prone, unbelievable, vague, or inconsistent explanations of injuries, psychosomatic complaints. So they don't necessarily have anything going on with them that you can see physically, but they are convinced that something is going on. That's definitely a big thing. A lot of times they come up with something just to be able to get out of the situation. Same with chronic pain with no medical explanation, self-destructive behaviors, often not wanting to take medications the way that they're supposed to, eating, sleeping disorders, depression or lack of energy, and then substance or sexual abuse history can also be there as well. Here's kind of the different categories of elder abuse. It's in your table or in your book, table 35.5. So I'll let you go ahead and look at that. Physical abuse. This is when inflicted bruises are easily found, sometimes not easily found, but the most common places are going to be places that you wouldn't necessarily see. So the butt, lower back, genitals, inner thighs. You can have some on the face, the cheeks or earlobes, neck, upper lip, inside the mouth. Pressure bruises that are caused by a human hand can be identified as kind of oval grab marks. Pinch marks are just handprints from being grabbed so forcefully. Human bites are typically inflicted on the upper extremities and can cause lacerations and infection. And yes, that definitely happens. Make sure that you inspect the patient's ears for indications of any sort of twisting, pulling, or pinching, and then evidence of frequent blows to the outer ear. So you might have some bruising kind of along the back side of the ear. If the patient has an appearance of being malnourished, other signs of neglect, such as lack of hygiene, poor dental care, poor temperature regulation, a lack of reasonable amenities in the home, that definitely may be a sign of apparent abuse. And then with regard to injuries on the genitals or rectum, oftentimes there's no reported trauma, but geriatric patients are still prone to be victims of sexual assault. So don't rule that out. That is all I've got for chapter 35.